This is the podcast for APTA Orthopedics. I am the Vice President of APTA Ortho, James Spencer, and my guest today is Dr. Janey Prodoehl, who works extensively in the world of temporomandibular disorders. She is a professor in the physical therapy program in College of Dental Medicine, Illinois, at Midwestern University in Downers Grove, Illinois. She has over 30 years of experience as a physical therapist, primarily in outpatient orthopedic settings. She is certified as a cervical temporomandibular therapist by the Physical Therapy Board of Craniofacial and Cervical Therapeutics, and she has her OCS. Janie has a passion for expanding and improving upon the care of TMD in our profession. And what I love about what she's doing and the conversation we're about to have is that she's working all over the place. She's advocating within our profession. She's advocating externally from our profession to make physical therapists a recognized provider in the world of TMD. And she's doing a lot to advance care within our profession and improve physical therapist care of TMD. She's currently leading a multidisciplinary team in the development of an APTA Ortho CPG on the diagnosis and management of TMD. So watch out for that. In the next couple of years, we'll have a CPG coming out that Dr. Prodell is the lead author on. Also through APTA Ortho, she has been appointed to the National Academies of Sciences, Engineering, and Medicine TMD Forum to work with other professions in developing care pathways for TMD. And finally, she recently won APTA Ortho's Innovative Practice Award to develop a toolbox that will live on orthopt.org. Three quick things before we get going with our conversation. Pop on over to orthopt.org and check out the nutrition toolbox that we do have that talks about physical therapist application of nutrition in their practices. It also will have a couple other topics that we're working on and we'll have toolboxes for soon. And the TMD toolbox is not complete yet, but you can expect to see that sometime in the near future. Also, the Innovative Practice Award is an award that we give out quarterly to people who are doing innovative things in our profession. So make sure you watch for the deadlines in your email box and apply for that award if you think you're doing something that's a little bit out of the norm and innovative in our profession. And finally, one of the things we talk about a lot in this discussion is how physical therapists are prepared to treat TMD through their entry-level education. But many of us put up barriers against ourselves, believing that we are not. So if you're watching this on YouTube, pop on down to the comments. Let us know, do you feel prepared to treat TMD? Do you already? How did it become a part of your practice? And let's get a little discussion going there. All right, with that, let's throw it on over to our conversation with Dr. Janey Prodoehl. Hi, I'm here with Dr. Janey Prodoehl, who is doing work in a lot of different areas focusing on temporomandibular disorders. And she's going to start with a presentation today that is related to her receipt of APTA Orthopedics Innovative Practice Award. And then after the presentation, we're going to have a nice discussion about all the different things she's doing and how physical therapists can incorporate treatment of this disorder in their own practice. So without further ado, take it away.
Thank you so much, James, and thank you to APTA Orthopedics for their support in this initiative to try and improve care for these individuals with temporomandibular disorders. Depending on when you went to PT school or depend on your frame of reference for this area, but know that this is an under-recognized and under-resourced area of clinical practice that myself and other colleagues are on a mission to try to improve care for these individuals. So patients often call this TMJ, but temporomandibular disorders is really a collection of musculoskeletal conditions affecting the joint and muscles and the nervous system in terms of how it controls those joints and muscles. That's very similar to other musculoskeletal pain conditions that we are very comfortable treating in orthopedics. But for some reason, we're not as comfortable treating this area, and that's the narrative that we're hoping to change. So TMDs are a global problem. They're not a niche problem. It's not just a few issues. The annual incidence rate is somewhere around 2 to 4%. So that's 2 to 4 individuals out of 100 will experience an onset of orofacial pain related to the temporomandibular joints or muscles. And in some instances, it's often recorded as the second most prevalent chronic pain condition in the US, which is quite staggering. So if you think about that in perspective, we don't have any problem treating the number one complaint, low back pain, but we often are a little fearful or we don't quite understand the temporomandibular area, and that is the narrative to change. The other shocking statistic of note here is that about 49%, almost half of individuals who have a first onset of temporomandibular problems will continue to have pain 6 months later. So this really becomes a persistent pain concern that we need to address. So in 2020, this report came out from the National Academies of Sciences, Engineering and Medicine that was a little buried by the onset of the pandemic, but it was a powerful report that really spoke to the need to improve care for these individuals. We've often relegated TMD to dental issues, but we've debunked that occlusion and the tooth position has anything to do with the onset or the persistence of pain in TMD. So we need a much stronger multidisciplinary biopsychosocial approach to treating these individuals with musculoskeletal pain. And who better than physical therapists to deal with that? Some of the current care gaps that this report highlighted were the lack of coordinated care, the over-treatment and harmful treatment, unfortunately aimed a little bit more at the dental profession with tooth extractions and oral surgeries, etc. The expense that patients often encounter, they are willing to pay thousands of dollars of out-of-pocket costs for non-evidence supported treatments, and how severe the impact on quality of life can be for these individuals when they are living with chronic pain. Identifying qualified healthcare professionals is one of the key barriers to effective care. And really, what is it about physical therapy that makes it so hard to find a physical therapist that will work with this population? There are some significant gaps in physical therapy, and this study, which was just done in Florida, had a relatively small response rate, but really I think speaks to the issue we have in PT, and that is about almost 70% of PT surveyed weren't necessarily feeling like they had adequate information on managing or treating this condition. We did a study that looked at the DPT current sort of practice of education in this area, and we found that yes, it's covered in almost all entry-level programs as it should be, but there is such a huge gap in how much of the content is really covered. It averages about 0.4% of the curriculum for TMD in entry-level DPT. And sort of if you compare that to other pain conditions that average around 9%, we definitely have a lack of training in this area. And there are also gaps in post entry-level training as well. So we definitely have a gap between some entry-level training issues and some postgraduate training issues. And the bottom line is we have to do better on both. What is it that we're afraid of when we think about temporomandibular disorders? We're comfortable treating other pain conditions that have discs, that have muscles, that have joints, but we are not as comfortable in this area. But entry-level practice is unlikely to change until clinical practice changes. And we want it, if we think about the goal of care, we'd like any patient that's having a pain condition to think PT first. We'd like them to be able to find a PT in their local community that can help them effectively manage their condition. If we can manage these conditions appropriately early, then we can maybe address that 49% who are going to go on to develop persistent pain. If we think about how the narrative around the care of low back pain has gone in this country over the last 10 to 20 years, we've moved away from a specialist first to a PT first, conservative care, de-emphasizing the role of imaging, supported management early on to prevent those chronic pain conditions, and really avoiding surgery and making that more of a patients who have failed conservative care. But unfortunately, when patients don't get good conservative care, they feel that they have no option but to go to surgery. And that is the narrative that we really need to change. So why is it then we don't get more patients referred to physical therapy? And part of it is just the training of medical and other medical and dental providers in understanding what PT can do. As a profession, we haven't really advocated ourselves enough in being able to help in the management of these individuals. So this author group did another survey looking at the dentistry profession. And they found that in Florida, 41% of dentists had no idea that PTs could do anything for TMD problems. Now, I saw a patient just yesterday who has been to 14 different providers, none of them physical therapists, who was outright told by their primary dentist that PTs don't do anything with TMD, so there was no point referring them. And she chose to come on her own and was crying at the end of the visit because she's like, this is the first time I feel like I have an option for how I can manage this condition. There's such a comorbid role between facial pain and cervical pain. PTs are well placed to manage musculoskeletal cervical pain. Why not the orofacial pain that goes along with it? So what do we need to do? We need to change our profession. We need to change the professional narrative in orthopedic PT that TMD, basic TMD, is highly specialized. It's not. It's a pain condition. It's a pain condition that with our biopsychosocial approach to other pain conditions, we are well suited to help these patients. Now, there are going to be patients who are more complex, who have more comorbidities, who have a more complex presentation, just as there are for patients with shoulder pain who don't do well with a typical orthopedic shoulder protocol and might need to go to see maybe a sports specialist or a shoulder specialist. And there are specialist PTs who do specialize in orofacial pain and headache. But for the majority of patients with first onset TMD, they should be able to go to their local orthopedic PT and be able to get good supportive early care. And I can talk about some of the initiatives that we have going on at the national level that will support all clinicians who encounter individuals with incident or first onset TMD. That's the only way we're going to help the largest number of patients and really start to chip away at that 49% persistent pain. The second thing we really have to do as a profession is do a much better job promoting our role in musculoskeletal pain management. The APTA obviously has the Choose PT campaign, but TMD is not really highlighted as part of that when it should be. We need to understand that a first-line referral for TMD needs to be to physical therapy or other providers that can provide this evidence-supported conservative care approach, which really is within the biopsychosocial model of care. So I think as a profession, we have a little ways to go, but I don't think it's going to take very much to get us there.
Yeah. I hear, I've seen you just now present evidence of PTs not feeling confident in treating TMD, PTs having the knowledge and ability to provide evidence-based care for TMD, and also evidence of other providers not providing evidence care. So it sounds like a big part of the barrier is within ourselves. What do you think it is about PTs or the PT system that even though we have the evidence-based knowledge to treat this condition, we're deferring we're letting others who are treating without evidence-based care into this space to handle these conditions? What is it about us, you think?
Yeah, I think it's a very intriguing area. I see it in my own students, though. I feel like in our program, I teach at an entry-level physical therapy program, and I feel like we have good education for our students, but there's something about this area that makes them a little fearful. And it's not until they actually work with a patient with TMD do they say, oh, that was awesome. I can do this. I have the skills. I have the wording. I have my pain neuroscience education background. I know what words to use. I know what exercises will promote relief of pain. I know what exercises will promote improved coordination. I know what manual therapy techniques I can use. There's nothing magical here, but I think there's something about the way perhaps people think about this area that they think it's highly complex. And certainly it can be highly complex for those more complex patients. But I think understanding that this is another orthopedic condition that certainly has other comorbidities and other things. But for PTs, it's not that different from other chronic pain conditions that are also similarly complex at appearance, but really can be effectively managed with not highly specialized skills. There's not magic techniques that you have to learn. If I would argue that any entry-level physical therapist going into an orthopedic setting should be effectively trained to manage incident low back pain, incident neck pain, and then incident TMD. I don't see it as a different thing. Now, how are we going to get there? We have to change hearts and minds. Just this morning, I'm calling around trying to find a PT for a patient referred from an orofacial pain specialist in a different part of the state. It's incredibly difficult. Calling clinics, do you see, oh no, we don't see TMD. Of course, do you see low back pain? Yes. Do you see neck pain? Yes. Why don't you see this? So when I saw the 2020 NASAM report, maybe it was COVID, maybe I had too much on my mind, too much free time, but I saw that as a call to action. I saw that as a say, we've got to do better, and we have to change our own narrative before we can expect other health professions to change their narratives. How can we tell dentists that they should be referring to PT when there are no PTs in their local community that will work with this population? So it's a bit of a chicken and the egg, and I think that it's time to change that. So part of the Innovative Practice Award that orthopedics gave me was to develop a toolkit for physical therapists that could help them get more comfortable with this area with some basic understanding of the condition, basic examination, and evidence-supported interventions, and then give them a toolkit to go out and bring this to dentists to increase awareness in the dental community. And this should be a win-win. This is a really effective way to meet the needs of your local community while you grow your practice. And again, I believe PT is in the best position to do this.
I love it. There's a lot of directions I want to go with this conversation, about how we can further impact the dentists and their knowledge of what we do. And so you mentioned NASAM, and I want to go into that and some of the work you're doing on that. But let's stay internal to PT for a minute. You talked about the toolkit, but you're also working on a CPG for TMD. And I think for therapists who aren't feeling the confidence to go out and bring this into their practice, that the CPG could be a way to compare what their knowledge is with what the best practices are. Could you talk about the development of the CPG a little bit?
Yeah, I really appreciate APTA and the orthopedic realm of the APTA for supporting the development of these clinical practice guidelines, because I think that helps to improve quality of care. And it also improves confidence that you are doing the right things for the right amount of patients, and that's fully evidence supported. So presenting that to other professions and showing the evidence base for what we say and what we do is incredibly powerful. So when we first proposed the CPG for temporomandibular disorders, the first hurdle when you propose a CPG is to show that there is actually enough evidence out there. And we had no problem meeting that bar. And in fact, we just reran the search for the interventions for TMD and got another 1,000 hits. So it's like, yes, we have to screen those down, but that will be at least another 70 to 80 articles we have to add to the CPG. There is so much out there, not all of it great quality, but there's certainly going to be enough to show us what are the basic entry-level skills that are common across orthopedic PT that should be expected from a screening, basic diagnostic exam, and then management. And it really comes down to what we're saying here. The interventions are not magical. They are our neuroscience education, our patient, our bio psychosocial addressing. They are basic exercises of rest and relief. They are motor control and coordination exercises. They are neck strengthening. They are neck control exercises. They are all the things that we do with maybe a less emphasis on some of the modalities. But that's very similar to other pain CPGs that are out there. And I do think when the CPG gets published, that will go a long way to addressing the education gap that we have and the clinical practice gap that we have. So hopefully educators at the DPT level will be able to use that to increase their confidence that they're teaching our students the right thing. And existing clinicians will be able to use that to say, oh, I can do that. This is not that different. I know how to do all of those things. And for people who are already managing this condition, it will give them confidence of what they can do. And then recognizing what is maybe in need of more specialist care is part of that. So I'm excited for that. It's turning out to be quite the undertaking. I think you go into developing a CPG and you have a timeline and you think, 4 years, that'll be great. Well, evidence is continuing to come out, which is a wonderful thing, but it means you're trying to constantly, get ahead of that. And obviously it's all volunteers. So sometimes life gets in the way, but we are doing great as a team. And we hope to have that out within, I would say, the next 18 months would be wonderful.
It's great. I can't say enough wonderful things about the CPGs. And of course, I'm saying that where I'm sitting, and I'm going to take a moment here just to plug some of the work that APTA Orthopedics has done in the realm of CPGs and that we will be doing. We got a lot of products coming out to hope to try to distill down all the information that is in these CPGs into something a little more digestible for the everyday clinician. So I hope people will keep their eye out for our partnership with PhysioU and some online modalities and a certification in CPG knowledge that's going to be coming out later this year. But I mean, you talked a little bit about, the 4 years and the amount of work that goes into CPGs. I mean, if people knew the amount of people and work and time that go into these things, it's impressive. It's huge. I'm blown away by it. I'd like to turn the corner a little bit and turn towards your work in NASAM. Would you mind telling us a little bit about what NASAM is and what your work is there? Because my understanding of it is that, it is work that's really having an impact on PTs being thought of as some of the experts in this field.
Yeah. The fact that we have such a strong contribution, I think, speaks to it. But what NASAM is the National Academies of Sciences, Engineering, and Medicine, which they are the organization that put out that 2020 initial report. And based on that identified the need for change, but it didn't really identify how we can affect that change. So following the release of that report in 2023, they convened a forum on temporomandibular disorders, and they appointed and sought input from different professions. And APTA Orthopedics actually supported physical therapy to be part of that conversation, and they enabled our seat at the table, which has really been a tremendous thing. Over the last 2 years, we've had multiple meetings and multiple ways to try to change the care for these individuals. And one of the big things that came out was the lack of a multidisciplinary unified care pathway in the US is really a barrier. We have all these silos of professions. We have dentistry here, we have medicine here, and part of medicine, we have PT and other allied health professions. And there is a sort of a barrier between collaboration, particularly between dentistry and some of the other medical professions. Earlier, I mentioned a dentist who doesn't believe that they are allowed to refer to physical therapy. Like, what? You can refer anybody. We don't actually need a referral. In most states, a patient can walk in off the street. So we have a barrier there. There were 3 different work groups that were formed from that initial TMD forum. And one of them was the Access to Care and the Care Pathway group, which I was a co-leader of and am a co-leader of. And so identifying what the barriers are and how we can really sort of make it transparent. When a patient has a first onset of orofacial pain, often they'll go to a provider that they already know. And for the most part, that's typically their general dentist. But sometimes as we become more recognized as musculoskeletal pain providers, that's often their PT, particularly if they know that their clinic treats that profession. Or they will go to their primary care physician or some other trusted healthcare provider. Depending on who they go and see, they should get the same information. They should be given basic understanding. They should be screened for TMD. There are free screeners available, very simple, effective screening to say, is this likely to be a TMD? There's very simple diagnostic exam, an understanding of the comorbidities, an understanding of any anxiety, stress that might go into understanding which patients are likely to develop a persistent pain problem and might need a bit more management. And so part of the pathway established is to understand if the initial provider that the patient encounters isn't able to enact that initial sort of screening, basic triage, red flag identification, and then referral on, who to go to next. And next would be a physical therapist, an orofacial pain specialist, or another dental professional with advanced training in TMD, or even their primary care provider if this is more of a systemic sort of pain condition problem that's manifesting in the orofacial pain area. And so we have to be ready for that. When those patients are coming, they shouldn't have to struggle so hard to find a PT in their local community who can enact the first line treatment, which is, again, is evidence supported. Now, sort of take a minute and think, what would you say to a patient with first onset low back pain or neck pain? You would give them supported self-management. You wouldn't do a lot of hands-on treatment. You would give them some education to reduce their fear. You would give them education about activities to avoid, activities to promote. You would probably provide some rest relief positions, some activities that would help them feel better. You would give them some basic exercises, some biopsychosocial sort of de-escalation of that pain condition, and knowledge that with, for the majority of patients treated appropriately initially, about 90% are expected to improve. And that's the number we need to change. PTs are well able for that, but not every patient fits that profile. Some patients are more complex. Some patients require more hands-on treatment, more education, more pain neuroscience education, more motor control training. They start to develop sort of, a spreading of pain, myofascial pain, starting to involve more of the facial nerve system, not just trigeminal. We're well equipped to address motor control issues in the musculoskeletal system. And so sometimes identifying maybe physical therapists who have a little bit more specialized training in this area. And there are a group of physical therapists that have that, but there's not enough of them in the country. So training more physical therapists in a little bit more advanced training is another area that we can grow our practice. So that NASAM clinical care pathway should start to be published in the next couple of months, we hope. And again, our profession needs to be ready to absorb those patients. If we're going to advertise that you should go and see a PT, then let's make sure there are PTs ready for these patients to be seen.
Now, one question that's burning in my head is, with NASAM, you're together with all these different professions who would really consider themselves the specialists of the mouth in that area, mm-hmm. right? And I wonder how they're taking to physical therapy coming in with our kind of conservative musculoskeletal care lens. How has that been?
Yeah, it's been interesting. I didn't really specify who's on this forum, but you're right. It's multidisciplinary. It's private healthcare. It's public healthcare. It's governmental agencies. It's clinicians representing most of the major professions. And there are some challenges because, everybody wants their own niche. And we've had to be really, really making sure that every profession feels heard. We're not going to get full consensus on the pathway for sure. And that is going to be a challenge. I think oral surgery is a tricky one. The oral surgeons often feel that they want to be involved earlier, but we know, as in low back pain, the earlier you see the surgeon, the more likely you are to end up with surgery. So it's been a little bit challenging. One of the things that we're looking to do is to just start the conversation And we're hoping that the conversation will generate more collaboration. And I think that's been one of the positive things that has come out of NASAM. Now, the dental profession is interesting. They recognized that they had a big gap in TMD care and other orofacial pain conditions that are outside or beyond TMD, things like trigeminal neuralgia, etc., headache. And in 2020, I think, they created a new dental specialty of orofacial pain. And there's about 600 specialists in the US. Again, these are specialists, highly trained dentists who can really manage the complexity in some patients of TMD. But they cannot be the frontline providers any more than the orthopedic surgeon can be the frontline provider for low back pain, for instance, or other pain conditions. So understanding, and I think that's been interesting because their profession, their specialty is growing, and they're still trying to understand where they fit in the healthcare environment. You know, they need to do a better job explaining to their own profession what they do and who to refer to them, so that we don't overburden them with patients that don't need the specialist care. One of the forum meetings we had a physician come in from a healthcare system in one entity, one part of a state, and they had sort of their own healthcare system, and they had been tracking low back pain, and now they track TMD for us to see, you know, what were the similarities different. And it was eerily similar how they're enacting a care pathway for low back pain in their system surely led to fewer orthopedic surgery referrals, which initially was met by resistance from the orthopedic surgeons. But ultimately, they have embraced it because now the patients that they are getting referred to them are better suited. They're going to have better outcomes. They're going to be able to help more people. They're going to be able to get people in more timely. So ultimately, it really did change when they enacted that low back pain sort of guideline. They reduced their imaging costs. They reduced their specialist referrals, and they more effectively managed the costs and the problems associated with with low back pain. We can do something very similar with with TMD. So I would say watch this space. We're not there. We certainly do not have agreement among all professions. Not everybody's happy. But I as long as we stick with the evidence support and we're not making claims that aren't true, I think that we should be able to change the needle. I believe it took about 10 years in the orthopedic low back pain realm to really change practice, where now new therapists don't even think about orthopedic surgery first. I think we could probably think it's going to take about the same for this, but that doesn't mean that we can't make sooner changes in helping these less complex patients get early care, more evidence-supported care now.
Yeah, we've kind of gone on a journey here talking about, you know, a lot of the challenges and the work that you're doing to really impact those challenges, whether it be PT belief that they can do this kind of practice, or other providers knowledge that they can refer to physical therapy for this, and also just the overall interdisciplinary treatment path and the improvements that are coming there. I'd like to bring the conversation back to where we started, back to your PT toolkit for this. Mm-hmm. And what are some of the things that are included in there that are poking at these challenges? And are there any little pearls or tidbits that you can give to people about the care of TMD?
Yeah, I think the toolkit is going to pretty much follow the recommendations of the care pathway, which are there are validated screening tools that patients could either complete themselves online and understand if this is a TMD. What are the red flag screening items that would need referral to a specialist, either an orofacial pain specialist, an oral surgeon, a neurologist, etc. So those, you know, early identification of red flags. Because I do think one of the things that they've identified in the medical profession is that physicians are not comfortable looking inside the mouth. And similarly, that might be one of the concerns that PTs have in terms of recognizing, is there anything sort of red flag here? So certainly the red flag items and making clear what the indications for referral to other specialties are. And then basic diagnostic examination. There are diagnostic criteria for TMD. that are supported by the American Academy of Orofacial Pain that are tremendous. But for regular physical therapists and other frontline providers, they are maybe a little complex. So there is now a brief diagnostic criteria for TMD that's much more manageable. It has been designed to be completed in a physical examination within about 5 to 10 minutes. If we can do that, then we can identify, we don't need to drill down to all the different subtypes of TMD. We can keep it fairly simple and say, is this more of a muscle problem or is this more of a joint related problem? Or the more common clinical presentation by the time we get these patients, it tends to be a mixture of both. If we can understand how to treat the muscles and the joint in this area, and then consider any comorbid conditions and other neck contributions, then we should be well placed to start with some basic early conservative management. So what would those be? It would be our basic neuromuscular reeducation, our basic therapeutic exercise, any manual therapy techniques to address joints and muscles, and then any of our education and patient empowerment kind of strategies. I think PTs excel at establishing therapeutic alliance with our patients, and that is so needed in this population who have already seen multiple healthcare providers and are so confused about what they should do. They've seen multiple images of what can happen to the joint. They've been told by others that they need joint replacements. We need to change all that narrative. And I think if we equip our PTs with that basic toolkit, then they should be good to go. So sometimes we'll do like a basic continuing education. One of the initiatives that we put forward in the toolkit was to work and partner with APTA Orthopedics to put out some free webinars to try and improve knowledge and confidence in this area. Done some studies with other colleagues in dentistry looking at the dental student confidence in TMD, and it's even worse than PT, I would say. And one of the things that we've identified in the dental student population is the more they get exposed to patients with TMD, the more confident they feel. It takes away that fear. So I think one of the prime initiatives of this the toolkit that we're putting out is, let's just demystify this. Let's take away the fear. Let's make this very practical. And it should be anybody should be able to implement this. Any licensed, qualified physical therapist in orthopedics should be able to work with the largest number of patients. And recognizing how to find specialist PTs is another area. So just a quick shout out to the Physical Therapy Board of Craniocervical and Craniomandibular Therapeutics, PTB CCT. They have this organization of physical therapists who are really passionate in promoting care for this group. And if we're looking for specialist care, those resources do exist, but we need to grow those as well. So that would be the other area that we can really promote as well.
You know, as I think about the work that ortho does, we often talk about research, education, and practice as our three prongs. As I hear you talking, you're on all three of those with your work, and it sounds like there's a lot coming out in each of those areas over the next year or two. So I want people to keep their eyes out for that. I'm going to add a fourth prong right here, though. As a private practice owner, I'm going to add business. And as I hear you talking, I'm saying to myself, why am I not marketing dentists and orthodontists in my area? Why, I feel comfortable treating TMD. Why am I not reaching out to these providers as a referral source? So I think there's a lot of work that people can be doing in their own communities in that area as well.
Oh, actually, that's one of the parts of the toolkit I forgot to mention, which is a marketing, I don't want to think about it as marketing, but promoting the role of PT for these patients to better serve them to dentists. There are some misconceptions. I think because dentists cannot certify a Medicare plan of care, somehow that got confabulated into dentists can't refer for TMD, which is, as we know, not true. So just educating our colleagues. I do a fair bit of dental education to different dental groups. And one of the things I say to them is your patients will love you when you can connect them with the right healthcare provider. And dentists don't have any trouble referring to other dentists who have different specialties, but they really don't feel comfortable going outside of dentistry. And they don't know the language that we use, and they're worried that they are not able to do it. They don't want to be in legal trouble. And then we just need to help them. We need to help our colleagues in other areas. And then primary care physicians is another one. Medical school education on pain conditions in general is quite poor. So how do we enable and give the tools to our primary care providers to get them quickly to PT? That's another area for potential outreach to our colleagues. So part of the toolkit will be giving some slides. We don't have any problems going out to orthopedic surgeons, so why don't we go to dentists?
Yeah. Well, I think we have taken all the work you're doing. We could go on forever, but is there anything we missed? Is there anything that PTs need to know about in this area that we haven't hit on yet?
No, I think that there is some amazing PTs doing amazing research and work in this area. There are, I'm certainly not alone in some of this work and all of the effort that's gone into this. I think the support of APTA Orthopedics in helping to move this needle cannot be undervalued. If we had not had a seat at the NASAM table, we would not be having this conversation right now. And so I really do say that your dues go to good things, even if you don't always see it. So recognize that it's changing practice.
Well, thank you for all of your work and your willingness to step up and be involved with NASAM. And I look forward to seeing the CPG in the near future and working with the toolkit as well. So thank you for all of that. And thanks for your time today.
Really appreciate it, James. Thanks to everyone.